Okay. I won't be calling on anybody at Wilford Hall today, so you guys are off the hook. I've got a lot of slides to cover, and thanks to a case last night, I'm kind of out of it. So if you guys hear me say something that's totally off, please just go, like stop talking or something. But the slides should be right. I actually haven't had a chance to run through them, but we'll get started. Daryl Baskin here, diabetic retinopathy. We're going to cover this and choroidal disease, and I don't know how we're going to do it in less than 50 minutes. I don't have any financial conflicts of interest. I will discuss whatever I want to discuss. So, three questions for you before I get to the next question, and I'll give you the answers at the end. In the U.S., what age group is diabetic retinopathy? In what age group is diabetic retinopathy the leading cause of blindness? So think about an age A to age B. Name the two most commonly described effects of hyperglycemia in the retinal capillaries. We're talking about pathology. And it's the really obvious one that every time anybody talks about pathology, they mention these two things. And what is the treatment for neovascularization of the iris and/or angle? Okay, this is what I ask medical students when they come and rotate with me because it gets them thinking and it's relevant. How does diabetic retinopathy actually cause vision loss? We'll call on, you guys aren't medical students, but I'm sure you'll get one of these. There's several. John, do you want to say just in over broad strokes here?
Diabetic macular edema.
Right, diabetic macular edema. Yeah, blurs the light hitting the photoreceptors. Right. Okay.
Vitreous hemorrhage.
Vitreous hemorrhage blocks some of that light getting there. And okay, well, we got a couple others.
Ischemia.
Ischemia, right? So macular ischemia is great. The light hits the photoreceptors, but nobody's home.
Traction retinal detachment.
TRD, and I think there's only one other one, and it's the one that nobody thinks of in the retina. So we'll just kind of go in three broad categories: capillary leakage, capillary occlusion, and neovascular sequelae. So we got macular edema, ischemia, papillopathy is the one I never think of because, again, I don't really care about the nerve. Vitreous hemorrhage, TRD, and NVG. So if pressure goes too high, the nerve's not going to be perfused. Okay, there are a lot of studies in this chapter, and they're mostly either antiquated or stupid. So I'm going to try to go over them quickly, and we'll move through. This is the Wesder, Wisconsin, epidemiologic study of diabetic retinopathy. It was done before Jason was born, 1980s and 70s actually, and before intensive glucose control is widely advocated. So it doesn't really reflect current diabetic populations in the U.S. So they said duration of diabetes is directly associated with the increased prevalence of diabetic retinopathy. I agree with that. I don't agree with this. After 20 years, 99% of type 1 diabetics had some degree of DR. That's most likely still close to true. 60% of folks after 20 years with diabetes type 2 had it. Again, I don't really agree with that because of intensive glucose control. I see people every once in a while, 35 or 40 years, no signs of diabetes. And again, some of that's genetic. But the frequency of diabetic retinopathy in DM patients over 40 years of age. Okay, here we go. By ethnicity, I thought this was interesting. 27% in blacks, 33% in Hispanics, 18% of whites. So maybe just remember relatively who's more likely to have it. But then again, socioeconomically, I don't know if they were really controlled. This is from some nationwide database in the U.S. This is a picture from Bill Benson. Shows a lot of interesting findings from diabetic retinopathy. No real macular edema. You can see just temporal to the fovea looks a little bit yellowish. Okay, I want you to keep that in the back of your mind before we get to the FA. You see cotton wool spots used to be called soft exudates as opposed to hard exudates. There's actually not any real hard exudates in this photo except maybe one superior temporally all by itself. You see some silver wiring, those little sclerotic white vessels kind of on the inferior temporal portion of that arteriole. And then there's some venous beading. See those sausage things coming along the inferior temporal arcade along the vein, obviously. There's an MA, there's a few MAs, there's some NV temporally. You've got, again, a lot of the findings that are interesting. Left eye looks not so bad, right? But then inferior to the disc, there's something going on there. And if we redirect the camera, you could see a lot of, I would not call this IRMA. Actually, the last one had some IRMA, I should have pointed out. There is a little bit of IRMA just temporal to the disc and a little bit maybe inferior to the disc. But really, this big frond we're seeing is NVE, okay? So this is back to the right eye. And that area I was telling you about, this kind of yellowish, totally not perfused, right? Notice the MAs that you see right around the foveal avascular zone. And by the way, FA is not the appropriate test to decide whether macular edema is present or not, because you can get leakage on an FA without real intraretinal fluid. Now we all get OCTs now. That sentence was written like dozens of years ago. Feel free to interrupt if you have a question. Okay. Pathogenesis, diabetic retinopathy. I'm going to read these to you. Chronic exposure to hyperglycemia leads to endothelial cell damage. Selective loss of pericytes, basement membrane thickening, lead to capillary occlusion, subsequent retinal non-perfusion. And you get that decompensated endothelial barrier function, and then you get leakage and edema. I'm not sure if there's a difference. But anyway, okay, so we're about to get into a couple more studies here. UKPDS and diabetes control and complications to control trial. Studies were invaluable. They basically sort of showed, okay, glycemic control really is important, and blood pressure control is important. Things that seem so obvious to us now weren't so much back then. And then pregnancy, severe carotid artery disease can certainly make diabetic retinopathy worse. So DCCT, you had a primary prevention cohort, and then you had a secondary intervention cohort. Basically, primary prevention, these are all type 1 diabetics. It's something important to remember about DCCT. Primary prevention, that means they didn't have diabetic retinopathy. And notice the size of these studies, 720, 715 patients in the other cohort. These guys all had mild to moderate NPDR, and again, type 1 diabetics. And so then they were randomized to intensive glucose control or conventional management. Conventional management basically meant you got a daily blood glucose monitoring. You got 1 to 2 insulin injections per day, and they didn't really adjust your insulin based on your glucose, okay? Intensive control is basically what we're all used to now. 3 or more injections or a pump, and you're monitoring at least 4 times a day, and you're adjusting your insulin based on that glucose, right? It's kind of like standard of care now. And the primary prevention reduced the risk of onset by 76%. The secondary intervention, again, they already had it, so we're just talking about slowing progression. They use this modified Ehlers-House scale by 54%. So yeah, you want to control it well if you can. They also showed that it reduced nephropathy and reduced neuropathy, right? They also showed that DCCT showed a reduced incidence of FMG, PRP, and diabetic macular edema. There's 2 things to get from this slide. One is fairly obvious, and so this rate per 100 PYR just means diabetes getting worse, right? So you have if you're in a conventional group, all those little dotted lines, 11% of your diabetes is going to get worse regardless. And if you have 11%, you're not really controlled that well anyway. But the other interesting thing is if you're at like 8% in the intensive control group, you're doing better than the 7% in the conventional group. And my thought is, the book doesn't go into this, is that you probably just have a lot more fluctuations if you're in the old school group. You're just going all over the place, so your sampling is going to range a little bit more. Okay, UKPDS, don't mean to onslaught you with these studies, but again, this is type 2 diabetics as opposed to DCCT. 4,209 patients. They're all randomized, again, intensive glucose control or conventional management, know where that's going. But then they looked at a subset that also had hypertension, and they gave them tight or less tight is what they called it, BP control. Less tight meant your goal was 180 or over 105 or less. And they didn't really push you beyond that too much. So, and then the tight control isn't even tight for us. It's 150 over 85. So needless to say, that slow progression of diabetes, that's why I'm mentioning this, not just because you need to know it for the test, but it's important to mention to patients. Most patients, if they got one right, they got the rest right. But every once in a while, you got somebody who's off the charts on their blood pressure or their cholesterol. So intensive glucose-controlled slowed progression of diabetes from their main cohort. Okay, let's keep on moving. I think we're on target. Spectrum of diabetes. Notice I don't have diabetic macular edema up here because it doesn't necessarily fall anywhere in particular on the order of events here. You can get it with mild NPDR or PDR or anywhere in between. So the yellow stars, let's see if it comes up, mean first year question. So John, this is actually a tough one. So I'll skip it, I'll answer it. What percentage of patients with no diabetic retinopathy will develop diabetic retinopathy within 1 year? I think this is from the book, but I couldn't find it this year. It was 5 to 10%. That's why we don't really care if they don't really make it back to their next appointment. We want them to, of course, but that's why we send them back to the PCM and say come back in a year, is because, frankly, it's pretty low yield. Now, definition of mild NPDR. Harlan, sorry. You were up with me last night, too.
know the exact criteria.
Okay, that's fine. There's actually two different grading systems, and the one that I go with is the MAs only. So we're just going to stick with that one. The other one actually requires like some other background diabetic retinopathy, blah, blah, blah. Okay, so what percentage of these folks will develop PDR within 4 years? Again, terrible question to have to ask, and so I won't ask you guys. It's 16%. I won't test you on this first two either because there's so many other things that are worth testing. But again, you miss somebody for mild NPDR, very low chance they're going to develop really vision-threatening complications, at least related to purely NPDR, PDR. Now, if DME is a little bit different. Okay, what's the definition of moderate NPDR?
More than mild, less than severe.
That's exactly right. When you're a third year, you get the easy questions. Okay, severe NPDR. Okay, how do we define that, Jason?
4-2-1 rule.
Right, and what does that stand for?
You have is it MAs in 4 quadrants?
Not MA, something else. Something very close. It has 3 letters instead of 2. DBH.
Okay. DBH in 4 quadrants. Venous beating in 2 quadrants. Or neovascular.
It's the German lady's name. Yeah. Irma. So what does that stand for?
Intraretinal
microvascular.
Yeah.
Abnormalities.
Abnormalities, right? And then how many double hemorrhages do you have to have in a quadrant? 20, right. Good, excellent. So, and there's the yellow star. Okay, there we already said all that, or you said it. And here's a picture. That's your double hemorrhages. This has both Irma and venous beating. See this? They used to call them Chinese characters. I don't know if that's politically correct or not anymore, but they are. It's not like talking about the way somebody looks. So anyway, they kind of look a little, you get what I'm saying. They're not the normal pattern, and they're more prominent than you would expect them to be. So that's Irma. Some people say it's like NVE that hasn't broken through the ILM. I take some issue with that because it's hard to know. You can't even see the ILM on OCT. So for us to say, because sometimes you do get that front of NVE, like that photo I showed you earlier, and it's really hard to know, is that Irma or is that NVE? Should we treat it? Should we not treat it? Okay, so what is the prognosis for a patient when they have one of the 421 criteria met? Josh, do you know?
Like whether or not they're likely to develop PDR.
Exactly.
I think it's like a third.
And that's a little bit less. That's 15% in a 1 year will develop high-risk criteria. And then the definition of very severe NPDR is having 2 of the 421 rule met, right? And then they triple their risk. So they have a 45% chance of developing PDR HRC in a year. This is actually still relevant, whereas when we go over CSME, it's just so boring now because nobody really uses it. Okay. So now, speaking of CSME, diabetic macular edema, focal or diffuse retinal thickening, right? It's hard to really differentiate that. Nobody, it's like, just sometimes it's really obvious, but other times it's definitely kind of overlap. You have a damaged capillary, you have a microaneurysm, you have decreased endothelial barrier function, right? And so you get this fluid accumulation. And then sometimes you get exudate, sometimes you don't. And now I'm going to show you this slide that you all have to memorize, but is completely, in my opinion, totally clinically irrelevant, right? Except when somebody pimps you in clinic. That's the only time it's clinically relevant. So I'm not even going to say it out loud. I memorized it as a med student, and frankly, I had it memorized when I typed it out this time. I just double checked, but I use it so infrequently it barely stays in my brain. So, okay, and hence the one of the only papers I've written that is even slightly worth reading, and it's 5 years old now, so it's not even that relevant, was on OCT and diabetic macular edema, and this is what I said. So you can quote yourself, I guess, if you want. So CSME doesn't address the most important factor in DMEs. You may know what that is. There's like one thing that it really doesn't get at all.
Intraretinal fluid.
Kind of quantitative retinal thickening, axial retinal thickening. So it doesn't really look at that at all. Like you could have 1,000 microns or just 50 microns, assuming you could actually capture that biomicroscopically. But it doesn't factor into the equation at all. It's either thickening or no thickening, right? So OCT takes that into account, obviously, and that axial retinal thickening has been shown more than any other variable to correlate with visual function, assuming everything else isn't torched. And so OCT, in my opinion, most people agree now. This is actually an argument to be made 5 to 10 years ago, and people would argue with you now. Everybody's like, oh yeah, that's obvious. Okay, so OCT is important. We got to go into ETDRS. So eligibility for the ETDRS, again, 3,700 patients. This was a crazy study, actually. I mean, it was good, but it's really weird. And you look back at it and you go, oh, this is kind of nauseating. So you had to mild NPDR through PDR. You had to vision 2200 or better in each eye. And this is like in the early 80s when you guys were all like still infants. Seriously, who here was born before 1980? Raise your hand. That's what I thought. Even the majors. All right. Okay. Not that I remember it either, but I was there. Assigned to one of three categories. No macular edema is category 1. Category 2 and 3 both had macular edema plus either what they called early retinopathy or something like that. Mild or moderate NPDR or severe NPDR to early PDR, right? So 3 categories. And in general, it's like early laser or deferred laser, and they had criteria for deferred laser. So if you got high-risk criteria, they were going to treat you. They weren't going to totally leave you out twisting in the wind. And all of these patients were randomized to aspirin or no aspirin, okay? But we'll get back to that in a moment. But within the early laser groups, we were talking about this last week with somebody, they did crazy stuff that doesn't exactly make sense to me, but I'm sure it made sense to them. They basically delayed focal, that's what the D means, and they gave either mild scatter or full scatter, okay? That kind of makes sense, right? But then once you get into macular edema, you throw in this extra variable. And so then they're like, well, let's do focal or immediate, or delayed or immediate focal, and we'll split that up into 2 different groups. And then we'll also do mild scatter or full scatter. So it's just crazy. And then they do a different permutation than that on these guys. It actually does make a lot of sense when you sit down and think about the way they were thinking about it. And again, they didn't have the answers. So what did they find out? Okay, that's the important part. So aspirin use had no measurable ocular effect. They list like 4 things, but basically no effect on the eyes. Now it does have an effect, and I'll talk about it tomorrow with AMD, and it's a little bit controversial. Reduced risk of cardiovascular events. Okay, well, I'll believe that. Early scatter laser. No, a small reduction in risk of severe vision loss, not indicated for eyes with mild or moderate NPDR. Oh my goodness, this is going to be a tough lecture. Mild or moderate NPDR. We obviously don't even use it for that now, and this is the study that showed us that it wasn't helpful. Otherwise, we'd be lasering everybody, and it might have been more effective in type 2 than type 1. Anybody know what severe vision loss is? We don't even talk about it now. 5/200 or worse. Just absolute. Well, this one, focal laser decreased. This is where we got the idea, or not the idea, but this is where we all prove, so to speak, that focals and macular grids work for diabetic macular edema, but it reduced the risk of moderate vision loss, which is doubling of the visual angle. It means you go from 20/40 to 20/80. So it reduced that. Increased your risk of increase your chance of gain, moderate visual gain, which is like the reverse of that, having the visual angle. Again, this is an old study. And then it reduced diabetic macular edema thickening. Okay, so let's move on. And so how do we treat DME now? It's important to remember lifestyle modifications, weight reduction, exercise, smoking cessation. I have to say I hardly ever, maybe never, tell somebody to lose weight, and I probably should. It seems like it's obvious to everybody in the room when somebody could barely fit in the exam chair, but maybe they need to hear it from us too. Exercise, I will emphasize, that's pretty easy these days. Exercise is good for everything. Smoking cessation, again, no brainer. And then the PCM modifications you got to have, but I blame it on I don't blame it on the PCM, but we pretend like it's a PCM's fault if their A1C isn't good. I'm like, oh, you need to get a good PCM, you need to talk to your PCM about this. You don't know your A1C, you need to talk to them. So I'll even write down on a piece of paper, this is your homework, right? I'll just write A1C. Tell your PCM that you don't want a thumbs up or thumbs down anymore. You actually want to know the number. So anyway, control the blood glucose, hypertension, and lipids. Steroids. Okay, the BCSC is insane in this section. They start talking about RVOs, which as if they're interchangeable or something. So we'll talk about steroids a little bit in the next few slides. Anti-VEGF obviously has a big role. Vitrectomy, somewhat controversial. If there's a membrane there, it probably should be addressed. And laser photocoagulation. So we're going to talk about those a little bit in the next few slides. This is an example of a study that the BCSC uses that's stupid. They got like 120 something patients in this study, and they're trying to show, and they're showing you these p-values, and they're acting like this is super important. Now, granted, I have not enrolled any prospective studies involving over 120 people, but still, the point is that this is not the best study. There are better studies to put in here. I'm going to show you some of them, and you may get tired of studies here in a few moments. READ 2 enrolled 126 patients, 20/40 or worse. The blue square, light blue squares were laser, and looking at this, you'd think laser's terrible. And you'd think even if you add it to ranibizumab, it's actually dragging the patient down a little bit. All right, that's what I would think. So again, small study, keep that in the back of your mind. Here's just some color images, this is a patient, and I just wanted to throw something in between all these graphs. So you see some exudates. It's not the best photo in the world, but this is typical for Wilford Hall at least. Got some hard exudates streaming to the center. Might have CSME, can't really tell. They might be a little bit thick up there, or used to have been thick. And here with the autofluorescence, I think this is really great for screening for diabetes. Nobody's taken me up on it yet, but it really highlights all with great contrast that something's going on. Now you wouldn't necessarily be able to say that's an MA, that's a double hemorrhage, that's a heart exudate. You could kind of get some sense of those, but you'd at least say normal or abnormal pretty easily. That this patient's already had multiple anti-VEGFs, and you could see a few areas of leaking. Again, you can't really use your FA to tell if they're leaking. And then of course we have an OCT. Now you look at this OCT. Right in the middle of the fovea, they don't look that bad. You see those hyperreflective foci on the right side of the screen, which corresponds to where the hard exudates were. You see some focal intraretinal fluid accumulation, little cystoids on the left half. So something's going on, but how would you treat? That's the question I'll ask you guys in my clinic a lot of times, and I don't really care about READ 2. I care about some of these other studies, and I'll try to highlight the things, assuming my brain will continue to work for the next few minutes, that I think are relevant. This is a really busy slide, right? Don't look at all at the upper right chart. First, look at the upper left. RIDE and RISE were both Lucentis studies that are basically the same. I can't remember what the reason was for why they ran two different studies from Genentech, but there was a reason. They had 759 patients. That's not a whole lot, but that's certainly more than the 126. And they had to have DME, and they had to be 20/40 or worse. And for 24 months, you see, I can't really highlight here, but right in the middle, there's a sham / 0.5 milligrams, ranibizumab, and ranibizumab, right? So basically, the black triangle was a sham injection. So for 24 months, they are getting sham injections. And then they cross over at 24 months. They went to 0.5. And so you see the little white triangle starts to go up a little bit on the graph on the upper left. They don't catch up, but they do look like they're heading in the right direction, right? That's and the numbers, by the way, are the mean improvement in best corrected visual acuity. So at the end of the day, you got 12.4 to 11.2, so more or less 12 letters of improvement versus 5. So there's still a big gap there, right? At the bottom two, there's this whole thing where people are dropping out. So they really thought, there's some bias in the way that the study was done and the way it was presented. So they looked at the people who actually got an injection after month 24 to compare them, because they had this last observation carried forward sort of statistical algorithm, which is the reasonable thing to do. So it actually is more like 7.5 to 7.8 versus 12 to 13, or actually on the right, bottom right. So anyway, the point is they actually start to catch up. And I would never deprive somebody of injections for 24 months, but the point is that ranibizumab is making a difference. So let me go to the next one for just a moment. So this was one of the more important studies that we've done. DRCR-NET's amazing. They did laser, ranibizumab, triamcinolone for diabetic macular edema. I forgot what protocol letter it is. But this is just the 2-year results. You see it goes 104 weeks. I just want to point out the 4 different groups. The very top, you've got ranibizumab and deferred laser. That's that black box, right? So they did the best, right? 10 letters or more. Right below that's the upside down triangle. That's ranibizumab and prompt laser. Then below that, you've got sham plus prompt laser. And then below that, the very bottom, you've got triamcinolone. Now, I want you to notice the triamcinolone, the little sideways square, what we call that, a diamond. The diamond, white diamond, goes up to around 24 weeks and is pretty close to the other guys with ranibizumab, and then it drops down. And basically, the pseudophakics in this group are not really highlighted here. I think I have one with pseudophakics coming up. So if I don't, I'll just tell you what the results were. But their enrollment criteria 30 over 32 to 2320. I know I'm losing people. This is important. So at 5 years, deferred beat prompt. So they actually just stopped looking at two of the groups, and they looked at deferred laser and the ranibizumab. And this is Lucentis. Lucentis in both of these groups, one got quick laser, one got deferred laser. Deferred laser did a little bit better. Why is that? Did they have medical students doing their focal macular grid, torching their foveas? I don't know. But the idea is that there was some benefit to waiting on the laser, and about half of these people never even got laser. Okay, so you'd be tempted to think that you should always defer laser, and certainly when the vision's worse than 20/50, defer beat out prompt even more. And if you look at the left, we're talking about like 7 or 8 letters. But then if they have better than 20/50 vision, you split them out a little bit, prompt beat defer, but not by much. We're talking 2 letters. But the idea is that not everybody's the same, and again, I do laser very selectively now, but for those juicy MAs with the nice ring of hard exudates, circinate ring of hard exudates, and I defer. I mean, and plus, if they've got lots of macular edema, what we would always say as fellows is, I don't know if the laser is going to take as well. Anyway, maybe there's more collateral damage, maybe there's more subretinal fibrosis. I don't know. And so what I was going to tell you earlier was that the pseudo-fakes did as well as Lucentis, or pretty darn close, in that one arm of the study. So they're pseudo-phakic, they're not going to get a cataract right, and so the cataract was kind of making the results look a little bit different. So, and that's why we don't talk about Ozurdex here, but it's not in the book. And but that's anyway. This is complex. I don't know how I thought I'd cover all this in less than an hour. But okay, so what's the advantage of prompt lasers? Anybody know?
You get better control of the leakage faster.
Maybe, but I'm talking more decreased what?
Their need for shots.
You decrease their need for injections just a little bit, and why that is probably what you just said, Josh. But they had an average of, and this is a course of 5 years, 17 injections in the deferred laser, 13 injections in the prompt laser. This is not a lot of injections. Rise Right, they're getting an injection every month. The DRCRNet study was as needed, right? So anyway, okay, and great visual results. We don't need to give it every month and give them a high risk of stroke, right? 3% risk of death in Rise Right. If you're in the injection group. If you're in the sham, you got like 1% chance of dying. So there's something that nobody likes to talk about that. It's a little bit awkward. I don't tell patients they have a 3 times higher chance of death if I inject them. I don't inject anybody Q4 weeks. But I do, if they have a history of stroke, I want to talk to them about that and really maybe explore laser or I think I don't use triamcinolone Ozurdex, some kind of steroid. Okay, this is my picture for macular ischemia. FAZ is irregular, right? It's not a nice little circle. It's not like a sandy beach coming in, a nice gradient. MAs tend to cluster at the margins. And if it's bigger than 1,000 microns, again, there's a lot of variability. We say 450 is a normal, 450 microns normal diameter for FAZ, but that's not true for everybody. So if it's greater than 1,000, you're almost always going to have vision loss. This is obvious. Look, there's tons of capillary non-perfusion in the temporal macula, tons of it. And you got some leakage. It's actually all non-perfused. So it's terrible. Not my patient. All right, screening eye exam schedule. So this is one I've shown you if I've shown it to you, I guess, because I don't show it to everybody anymore. But when I used to run the diabetic screening clinic, if you have diabetes type 1, when should you get your first exam, Dr. Powell?
10.
3 to 5 years afterwards. And probably nowadays, and people are coming in with pre-diabetes all the time, so clearly nobody's following this. Okay, and follow up once you've come in that first time, assuming you came in at 5 years. How often? Yeah, annually. So assuming they don't have like something going on, right? Diabetes type 2, should they get their first exam?
When they get diagnosed.
Right, because they might have already had it going on for a while, right? That's what we say. And then you got to check it out yearly. Okay, Prego and diabetes type 1 or 2, time of first exam. Yeah, well, if you're trying to get pregnant early in the first trimester, as soon as you can, basically, right? And then how do you follow them up? This is a bit of a trick question, so I'll just give it to you. If they don't have anything going on, you want to see them about every 3 to 12 months, but that's what they say. And then if it's severe NPDR worse, you want to see them every month. Okay. Have a low threshold. Bring them back frequently. Here's our little diagram again. And definition of PDR is neovascularization, basically anywhere. Pre-retinal hemorrhage, vitreous hemorrhage. Makes sense. Assuming they don't have like a big vitreous hemorrhage from a PVD, right? That's pretty unlikely. You don't just call them PDR for that. Okay, so what are our 3 categories of PDRs? Anybody know? We've got HRC, right? And then we've got no HRC, and then we have one other one the book talks about just briefly called advanced. So all we really care about is PDR, HRC. Who wants to be called on for this? Anybody? No. All right, Benyon.
Oh, great.
You know your criteria?
I don't think I do.
All right, Vu.
Neovascularization of the discs with vitreous hemorrhage.
Okay, that's one.
Neovascularization elsewhere.
Quantitate it for me. How much they need to have of NVE elsewhere? NVE?
Is it this size?
1.5 disc area.
Yeah, is this
Less than that. Half a disc area
Half a
of
disc area.
NVE plus something else.
plus vitreous hemorrhage?
Right? And then what's the other one? The one that doesn't require vitreous hemorrhage.
MVI.
Nope. NVD, how much?
Greater to disc diameters?
Nope.
Greater than a third of the
Quarter
disc
to a
area.
third disc area, right.
Right.
And so just for the
Disc
record,
area.
this is one of my favorite pimp questions I'm giving away, but I'm leaving so you can get all my good pimp answers. Pimp answers. All right. The disc is there, right? You can have NVD all over the disc, but if your NVD extends beyond the disc, it still counts as NVD up to a disc diameter from the disc. So you can have like 5 disc areas of NVD. When I first read that, I was like, wow, just like blew my mind. Okay, there you go. And then advanced PDR, anybody know what these are? I asked this question of a retina attending when I was a resident. He didn't even think advanced PDR was a category. It's an antiquated category. So if you have ptysis or enucleation due to bad diabetes, if you have vitreous hemorrhage precluding the grade or being able to see it, if you have a really bad TRD involving the macula. Okay, moving along. We have so much to cover. All right, PDR therapy, anti-VEGF. I'm just going to read the slides now. Anti-VEGF for PDRs, gotta be super careful. You almost never see me do it, but I know some people that do it all the time. I saw the bad cases when I was a fellow. Precipitate a TRD and their retina goes like that, and you go, I never want to see that again. So if their hyaloid's off, which if it's off, they're probably not going to get any PDR, but whatever. But if they don't have a tractional membrane, maybe think about it again. This is the subject of a totally different discussion. Side effects, you can get a combined TRD RRD because you could tear it. Like I said, you could like that TRD, but also tear it. And then there's some evidence of increasing macular ischemia. So be careful, and it better not be you making that decision. Vitrectomy in PDR has a bunch of indications, right? Non-clearing vitreous hemorrhage, TRD threatening the macula. If I can't come up with good questions, I'll come up with a bunch of these on the test. So yeah, it's probably not worth memorizing. I'll try to stay away. Or if I do, it'll be a really obvious one. I mean, there's all kinds of stuff. Ghost cell glaucoma, anterior hyaloid, fibrovascular proliferation, diffuse DME with VMT, dense premacular subhyaloid hemorrhage. There's all kinds of reasons to do surgery on these guys. So that's why, and these guys benefit from early surgery, in my opinion. Most of them. Laser photocoagulation. All right, we'll talk about that here in a moment, I think. If not, oh yeah, here we go. Diabetic retinopathy study. This is, again, an old study. You've got lots of old studies back here. And severe vision loss. Here, I'll say. Okay, all these patients, 1,700 patients, bilateral or bilateral severe in PDR, vision pretty bad. They're randomized to photocoagulation or no photocoagulation. And lo and behold, it's all obvious again now because we're benefiting from the results. Reduces the risk of severe vision loss, 5/200 vision by 50% if you treat. And the eyes that got HRC benefited the most. And then, complications, you can, just from the laser, your vision can decrease by 1 or more lines. And 11%, 1 out of 10 patients will lose vision. I don't tell patients that because I didn't know it. Some of them will lose vision. They also use 500 micron burn spots, and maybe they torch the retina a little bit more. Visual field loss in 5%. Okay, soapbox. Diabetes and cataracts. Cataract surgery will worsen your whatever you've got going on with diabetes. So you need to think about treating it right before or having very close follow-up, fundus follow-up afterwards, not just your cornea looks nice and your refraction's good, okay? I've seen this happen, and we have a good system here. Number 2, do not use silicone or tetanus IOLs in diabetics. Please don't. Who was I doing a laser with last week? Somebody in this room. Nope, nobody in this room. Laser retinopexy.
Oh,
I did one with you, but
I don't think that was this.
I think it was Mike.
Yeah. It was somebody. Sorry, I don't remember who it was. My brain's not functioning. And they had a tetanus, and it was terrible. It was just the laser would hit the edge of the IOL and reflect somewhere else. And if it's endolaser, it's still a tough view, but at least your laser is not being redirected by it. But with laser indirect ophthalmoscopy, painful. So please think about that. If you think you have a diabetic patient, again, you can't. And then also, if they have a PVD, use Tecnis. If they don't have a PVD and you think they might get a tear someday, please don't use a Tecnis. So, okay. All right. You already know about management. We've kind of gone over it. Education on all of them. Here's a follow-up. It just gets shorter. It's a year even if they have MA. So if they have MAs, just bring them back in a year. Again, they have a low risk of ever developing PDR in the next year. And then we treat PDR. And then this is more for my clinic. They got another A1C. I explained to them what A1C means in their own terms, Spanish or English. Remind them of comorbidities. Anemia is one that a lot of people have and are not really getting it treated well, and that often goes hand in hand with nephropathy. And then they need regular eye exams because we're going to catch it before they will. This is when you refer to me. If they got severe in PDR, go ahead and send them over to retina clinic within 3 to 4 months, and the other ones pretty soon. Okay, we got a lot of questions. I'm just going to run through it. 2 major risk factors: duration, severity. 2 medical conditions are definitely associated with worsening DR: hypertension, dyslipidemia. Okay, how often should women with gestational diabetes be examined?
Depends on
how bad they are.
Nah, they're not at increased risk. So just gestational is totally different, right? Otherwise, you guys would be seeing a ton of people with gestational diabetes. Think about it. I mean, how many of us have friends or loved ones that have gestational diabetes, but they're not going for eye exams? Okay. So did you think about the age group, age A to age B, where it's the leading cause of blindness? Anybody want to say the first part?
20 to 50.
2064 is what I think the book says, but yeah, I would have said 20 to 52. 2 most commonly described side or path effects of diabetes in the retinal capillary bed.
Affects the pericytes.
Right. Loss of pericytes and something gets thick.
Thickening of the basic membrane.
Right, good. And then the iris to get like what, lacy vacuolization or something like that. Okay, treatment for NVI and VA. Anybody?
PRP.
Yes, but a lot of folks just get these little tufts of NVI that you can just watch. If they got full PRP and you see a couple tufts there, just watch them. It doesn't necessarily mean your PRP failed. If it starts to get contiguous or they get a lot, you obviously don't want them to get NVA. I don't want to block off the angle at all. So if I see NVA, I'm going to treat it. Don't use gonio as much as I should, and I will do PRP. So a lot of references here, and that's it.